Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the Quorum Podcast. Today I am with Dr. Fredrik Granholm, who is a Swedish flight physician. He's head of one of the air ambulance bases in Sweden. He won the Teacher of the Year in Emergency Medicine, and he runs the Tactical Trauma Conference. Fredrik, welcome to the podcast.
Thank you. Thank you very much. It's an honor to be invited to the podcast.
We've been trying to work on this for a while, and I'm glad our schedules lined up.
Yeah. It's been a long time coming.
So your name keeps popping up, and where I found you originally was the Manual for Austere and Prehospital Ultrasound.
Yeah.
And that came out in 2019, I believe it was. And I looked at the contributors. There was only one person from Europe.
Yeah.
And that's you. Yeah. So I had to reach out. Yeah. I had to, and we connected.
Yeah.
And we've been keeping tabs on each other. But we first time we've had a chance to sit down and have a chat.
Yeah.
So tell me about your background in pre-hospital medicine and ultrasound use.
Yeah, sure. I live and work up north in Sweden. My clinical background is as an anesthesiologist and intensive care physician. After a couple of years, I sort of drifted into emergency medicine as well. So I got board certified in emergency medicine, did a Scandinavian fellowship in pre-hospital critical care, and sort of really liked that kind of environment. I was very involved in all sorts of education and training, mainly trauma and critical care. Different kinds of tactical medicine aspects. And nowadays I work as a medical director for a HEMS program. Also work as a clinical HEMS physician and do the odd shift in the ICU now and then. And my interest in ultrasound started during my anesthesia residency. And that was around 2005 or 6. The machines were big and bulky. We had one machine that we used entirely for central venous access. Couldn't do anything else. But I got used to that kind of machine, and I went to a conference in Rome, at the WinFocus conference in 2010. And WinFocus is like the great big conference or congress on POCUS ultrasound for different situations and aspects. So I was listening to one speaker at the conference, and he was talking about the pre-hospital use of ultrasound. And I was really amazed and started to think if that really was possible, because that was before the machines got small and really able to use them in a pre-hospital setting. But this conference also made me more interested in ultrasound use in general. So I started to use it as a tool for my resuscitation and for diagnostics and for procedures as well. And the book you mentioned, the Manual of Austere and Prehospital Ultrasound, it has a funny story behind it. I went to the CTTMC conference in the States, Critical Care Transport Medicine. I think it was in San Antonio in 2018, perhaps. And I met this physician, Ben Nicholson, who's an emergency physician in, I think he's in Virginia now. Started to talk. Turned out his wife was from the small place where my HEMS base is, she's Swedish. So we started to talk, and after a couple of months, he reached out and asked if I wanted to be part of a book project. And he was doing this book on pre-hospital ultrasound, and thought that as an anesthesiologist, the nerve blocks chapter would be good for me. So I got involved in that, and it was a great experience to delve into that kind of topic. So that's how I got involved in the ultrasound side from a more pre-hospital perspective.
And as the ultrasounds got smaller and smaller, you started using them on the HEMS. So what, the M Turbo, is that the first one you used on a helicopter, or what was the first one?
No, we got the IVIS. So that was the first one that we started to use. So we've been using that in our program for like 6 or 7 years. But we just changed it now, so we're going to use the butterfly instead.
Nice. Yeah, I'm fond of them as well. You were kind enough to take one of our ultrasound probes that we got from China, and
Yeah.
is a complete knockoff. And tell me about your experiences with the C10RL probe.
Yeah, I was really amazed actually. It's a very potent little machine, and I tried it for different kinds of protocols, like the usual the EFOS protocol, the Rush protocol, like vascular access protocols and stuff like that. And it was very potent. It could do most things that a more expensive machine can do. Of course, there were some flaws, and I think that the software side was a bit dodgy sometimes. But overall, it was a good experience. Actually, I took it to one of my friends who did a PhD on prehospital ultrasound in sort of the Austere environment as well. She's been doing some research in the Himalayas, Everest, and with the divers, and she was also quite impressed actually.
Yeah, we found that we couldn't quite get foreview on the cardiac very well. So the cardiac side of that's not the greatest, which is why we use the IQ. We have 3 IQ butterflies in the classroom. It's hard to beat that one. But that was interesting to hear your feedback on that. So you've worked in different organizations teaching and using ultrasound. Tell me the different needs for ultrasound between the military, NGOs, or pre-hospital, or an austere clinic.
I think that, I mean, it's very popular to implement ultrasound into different organizations now. And it's always fun to get new gear. If you're in healthcare or military or the police, it doesn't matter. Everyone puts a lot of energy into getting new stuff. But I think that you have to do like a needs analysis before you start thinking about the ultrasound and before implementing. For example, if you're an NGO, you're working at a remote clinical, perhaps sub-Saharan, you may have a mixed patient cohort. You may have all ages, from babies to the oldest patients, lots of infectious disease, pregnant patients, and well, you will need to think about what kind of protocols to use. Because if you're working in a military unit, it may be mostly trauma, and perhaps you'll have to add some prolonged field care capabilities, but you may not need the ultrasound protocols that will deal with infectious disease, perhaps. So you'll have to think about the needs in your unit or your clinic before you start planning for your education.
Every one of those is going to have a different needs analysis, isn't it? I mean, the military is one thing, but even different NGOs you go out with, they're going to have a different needs for ultrasound. Are you finding the IQ Butterfly would probably meet most of these requirements?
I think it's very all-round, and I think it works for most situations. What I really don't like about it is that it's not that rugged. I'm still looking for the perfect ultrasound probe that is really rugged and made for the remote environment. Because I think that most are made for the in-hospital environment, or perhaps the ordinary EMS or HEMS environment, not for the really rugged terrain that you may stumble upon.
Yeah, they get drops, don't they? And then they can, some of the elements might break. I'm surprised that somebody out there hasn't come up with a ruggedized option, since there would be tons of people who would purchase it. But what are some pearls and pitfalls that you found when implementing ultrasound?
Well, as you know, pre-hospital ultrasound is within the scope of practice for non-physicians, and that has been shown in numerous papers. But I think that you need to do the needs analysis and think about why you want this capability in your organization. Because you know that in a remote environment, you have to carry stuff in, and that will impact something else. So you have to think if this ultrasound capability will improve patient care. Will it improve triage or diagnosis or treatment or safer procedures? Because if it will not improve patient care, you should not get this into your system. It's just going to be a waste of money, and it's going to weigh a lot and things like that. But when you've done your needs analysis, you have to plan a training program which aligns with the needs. Most training programs should have a sort of a the basics of ultrasound and some formal didactics. There are lots of online resources that can be used, but there's also a need for more direct supervision. So you have to be supervised by someone who can show you hands-on what you're seeing and how you should interpret it. And there are some discussion how many scans do you need to be fairly proficient. And a lot of people think that around 25 scans with 100% quality review, that makes you acceptable in that kind of modality.
That is the problem, isn't it? So we can, so we have the APIS course this weekend here in Malta, and we're going to show them the EFAST and how to look for liver abscesses and lots of different stuff for austere practice. But what good is that if they don't go out and use that? And that's the challenge, isn't it? To have someone to be able to review your workbook, and we have some of that in Tanzania at KCMC. We have donated IQ Butterfly there and up the hill in Kabosho District Hospital as well. So you can get some review from Dr. Francis. But yeah, how do you document this? I mean, the ultrasound course I did in the UK from the Royal College of Emergency Medicine is 2 tiers. It's a 2-day course, and then you have a workbook that you must fill out. I think it's 100 scans signed off by a consultant, and then you're allowed to be a level 2 practitioner. Do you think that's something to aim for in austere environments?
It's very ambitious to have 100 scans. And I think that it's impossible for most organizations working in the remote environment. I think that it's feasible to aim for like 25. And I think that you should focus on one kind of protocol. So you start with one protocol and you get used to that and you get familiar with it. Like you start with the EFAST protocol, the extended focused assessment with sonography in trauma. That's fairly easy. You have large structures, the anatomy is fairly simple, and you're looking for 2 things. You're looking for where blood can accumulate, and you're looking for a pneumothorax. So I think you shouldn't aim too high. You should focus on one scan and get good with that, and then you can build on the different modalities and the different protocols when you're more proficient in the scanning.
With the IQ Butterfly, it allows you to record. So would that be acceptable if you're out in an austere environment somewhere to do 25 scans, record them, send them to, for you said 100% review of 25 scans, you can send them to an ultrasound specialist. Would that suffice for training?
Yeah, I think it's a great way to get proficient, and the possibility to record. I think it's opened up a lot of possibilities. So I would really recommend anyone wanting to become better to do that. And I think that we'll see some more possibilities in the future with live scanning and where you can have a live feedback from a tutor or another one who is proficient in ultrasound.
That is one of the benefits of the IQ Butterfly, where you can remote in to a specialist and he can control your IQ probe and change some of the settings and give you immediate feedback. That would be preferable if you have the bandwidth.
Yeah, the problem is often the lack of bandwidth where you're working. But if you're able to record, I think that's a great way to get feedback on how you're performing and what you're seeing and how you should interpret.
That's the specialist, isn't it? That's the 100% review of having someone to review this. I'm surprised that there hasn't been an organization that does this. It provides some top cover for training for the ultrasound. That's maybe something we should take a look at. Fair enough. So 25 scans with 100% review from a specialist. At that point, you would say someone is proficient at ultrasound in austere environments.
Yeah, I would say that. But I think that, again, you have to focus on a few protocols when you start. You shouldn't aim to do 25 scans EFAST and 25 scans with a rush protocol and 25 for a nerve block, because even if you have 25 scans and they've been quality reviewed, it's going to be too much if it's a low volume for you. So I would say that you start with something that is fairly basic, and you can build on that as time goes on.
Fair enough. That's finding one that works for you. We
Yeah.
focus on EFAS in our APIS course. You had to pick one, so we can discuss Rush. But yeah, EFAS, you're right. It does seem to be easiest to pick up and work with. But the challenge is getting those scans with oversight.
I think that the challenge for most people who are not used to ultrasound is just using the probe and understanding what you're seeing on the screen and how that aligns with your movement of your hand and stuff like that. So that's why I recommend the EFAST, because it's like intuitive, what you're seeing on the screen, the anatomy, how you move your hand, and it's easy structures. You see the liver, you see the lung, you see the heart, and so on.
Like all skills, it's a matter of dirt time. We call it dirt time in the Army. How much time do you spend in the rough areas doing the skills you're trying to work on? And ultrasound's no different than any other skills. It's just a matter of experience and hands knowledge, and that's the challenge. Do you have any suggestions for the person who is just starting out? They took the 2-day course, they have their own probe, and they're off into the wild wonders of austere medicine. What suggestions do you have?
I think that you should scan as much as possible, just to get a reference how things may look and the different ways that you can use ultrasound. But it's very important that you understand that clinical context is paramount. I mean, you have to have a sound basic knowledge in the clinical exam. You must be able to do a good history. You must have your knowledge in anatomy and physiology. There is an Australian emergency physician, like an ultrasound guru, I would say. He wrote a nice little book called Emergency Ultrasound Made Easy, Justin Bowra. And he's got some golden rules of ultrasound. And one of the rules is a fool with a stethoscope will still be a fool with an ultrasound. so you need to get the basics right. Yeah, it's like the police medics in the UK. They have a motto from 1878: the basics done well always. So do the basics right, and you must know your anatomy and physiology and the clinical exam and things like that. And I also think for a beginner, it's important to understand that you should only ask questions that you can answer. The questions should be binary. Is there fluid in Morrison's pouch? Yes or no? Is there a pneumothorax? Yes or no? Don't start with the question, why does this patient have pain in his abdomen? Or why does this patient have a dyspnea? Start with the binary questions.
That's a good advice for someone. They're not expected to have a Star Trek tricorder answer to everything. That they need to just choose one view and then ask themselves, yes or no, is that what I'm ruling out? I like to comment about basics done well, and Special Forces, we were asked by random people what makes us special, and the answer is always going to be, we know the basics well. So we're good at what we do, not because we free fall at 65,000 feet with a tactical nuke strapped to us. That's not what it's about. It's how well can you do immediate action drills on your weapon, or how well can you put a tourniquet on blindfolded upside down. Those are the basics that's done well. And ultrasound, start with the basics and build on that.
Yeah.
So where do you see ultrasound, pre-hospital ultrasound going, Fredrik? What's your 5-year wish list, or where do you think, what's going to be the new changes coming in?
Actually, I think we'll see more rugged ultrasound machines, and I think that we'll see more sort of live scanning and live support with the scanning as well. I think, this is my guess, but I think that the military will be a driving force behind that, to have like 18 Delta's Special Forces medic who can connect with the physician to get information on what they're seeing and how they should interpret their ultrasound scan. I also think that as more and more people get more proficient in the basics, like the EFAST and the RUSH, we will see use in the pre-hospital setting with nerve blocks and more advanced modalities as well.
As far as nerve blocks, I mean, you wrote the textbook. What would you suggest would be a first one for an austere paramedic to specialize in?
I would say that you should learn 1 or 2 nerve blocks that will give you most bang for the buck. They should be safe, and you must understand that these will not be like 100% nerve block that an anesthesiologist will provide in the OR. The nerve block will be for pain control, and most importantly, it will be like an adjunct to other pain medications or to sedation. So start with the basics, start with perhaps 1 or 2. If you're going for the lower limb, a femoral nerve block perhaps, or a popliteal sciatic, ones which are easy to visualize and where you don't have a lot of risks with performing it. And this may be good for fractures or amputations and things like that. So 1 or 2 nerve blocks. If you're going for the upper extremity, just learn the axillary nerve block. Also easy to visualize and with fairly low rates of complications as well. And you must remember that you're not going to be an anesthesiologist. You're just going to help the patient to get from the austere environment to definitive care. And you want to do that with as good pain control as possible. So this is just an adjunct to the other treatments that you have. But it's very important that you can facilitate the transport, because if you can reduce the systemic opioids or the systemic ketamine, you can have a much more stable patient. The patient can have a patent airway, he can be breathing normally, and it will be a much smoother evacuation or transport.
I'm happy to hear that. The 2 that you suggest are the ones that we're going to see most often in an austere environment. I haven't done an axillary. I've done quite a few femorals, and those, even before ultrasound, those were somewhat safer. Just as long as you're lateral of the vessels, you're pretty safe. Yeah. And of course, the listeners here should buy the textbook and read your chapter on the nerve blocks to go a little deeper into that.
I can recommend some other options as well. If you want to look into nerve blocks, there's a fantastic organization called the NYSORA, New York School of Regional Anesthesia. And they have a lot of stuff which is free online. Some is for a cost as well, but a lot of the videos on blocks are free. So look into the femoral nerve block, for example, and you can start from there.
Do you have any other suggested online or FOMED resources?
There is a great resource called coreultrasound.com, or if you Google 5-minute ultrasound, 5-minute sono, you'll get to that website. Short videos, it's short and to the point and really useful. So coreultrasound.com. And if you want a free textbook, the Sydney HEMS has a really good little textbook. Looking at it right now, it's called the STORM Manual, Sonography Training Oriented to Retrieval Medicine. So Sydney HEMS STORM Manual, Google that.
The Australians also have the Life in the Fast Lane website, which has a ultrasound core compendium that has been helpful for me as well. A lot of good resources. And
I would also recommend anyone who is working in the austere environment to have an app, an ultrasound app. There is a free app from the Ohio State University, I think. If you check on the App Store, Ohio State University Ultrasound, you'll find a nice little app, totally free, great for teaching and training and just refreshing your memory.
I hadn't heard of that one. That's and a storm. I'm looking forward to both of those. Well, Fredrik, do you have any other final comments or things that you would like to share with our listeners about ultrasound or anything that you would find interesting?
I think my take-home points are that you need to have the basic clinical skills before you start and consider ultrasound. So start with that and do your homework. What are your needs for yourself and for your organization? And then you do a plan for the training and align that with the needs. And you start with one protocol and get used to that one and get used to handling the probe and the anatomy and so on. And you build from there.
That's good advice. Thank you, Fredrik, for your time on discussing ultrasound, and I look forward to having you back on our podcast.
Thank you, Aebhric. It's an honor.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is Corum, C-O-R-O-M, corum.org.